Hello, welcome to another edition of Labor's Worldview TV. I'm your host, David Johnson. Today we're going to be having a special guest talking about a Medicare for All, a single-payer workshop coming up about a week or so at the Champaign Public Library. So stay tuned. Well, welcome to Labor's Worldview TV. Could you introduce yourself to the viewers?
Sure. Well, hello, David. Good to be here today and to the wider audience out there. My name is Pat Simpson, and actually David and I go back many years now. I was once a co-host of the radio Labor Hour, and currently I am involved with David in the Illinois Single Payer Coalition Champaign-Urbana chapter. I should also mention that in addition to that work, I've been a long-time social justice activist in the community. I'm retired from Loyola University, Chicago. I should emphasize that I was not an expert in healthcare policy there, but worked in the area of labor relations, actually. And I should also mention that I am a member of the CU chapter, the Champaign chapter of Democratic Socialists of America. And I think that one of the important things to talk about when we talk about the Illinois Single Payer Coalition, which is a statewide organization that's been around for quite a number of years, over a decade, and they have long been pushing for a single payer system in the United States, also even pushed for a time or considered for a time looking at statewide programs, single payer programs. And what we mean by single payer, and we'll talk a little bit more about that when we get into Medicare for All, but what we really mean is we're looking for a system where it's publicly financed and privately delivered. Essentially, it is, if you will, a government program similar to the kinds of programs we see in many different wealthy industrial countries in the world. It's important to emphasize, I think, too, that when you look at a single payer, when you actually talk to healthcare advocates, healthcare policy experts, healthcare professionals, increasingly what they're envisioning in terms of an overall perspective with regard to healthcare and a healthcare system is a human rights perspective. And as this slide will indicate to you, a healthcare perspective that is guided by human rights really understands healthcare as something that needs to be free and accessible to all. Ability to pay is not important. Quality is, but not the ability to pay. And this is where the human rights perspective comes in, fundamental freedom, really. Freedom as a human being to develop as well as any given human being can. They need security. And one of the most important forms of security is, of course, being healthy and ensuring your health. Martin Luther King, this other slide will indicate this, was someone who understood this very profoundly.
All the way back in 1967, 68.
Absolutely, absolutely. And he was able to say at that point in time that, in point of fact, inaccess to health care is perhaps one of the most immoral types of injustices that can be found in the world. And so this is the kind of perspective that guides us in the Illinois Single Payer Coalition and many other people who are advocating for Medicare.
And so this human rights approach to healthcare, how does that fit into the U.S. Profit system? I mean, in this country, healthcare is it's treated just like a commodity.
Absolutely. I mean, I would say that it doesn't fit in very well at all with the profit system. And here's, I think, another slide I love. We get to show Chris Rock here today, a quote from him. But to give you a sense of what the profit-making system thinks of in terms of healthcare, there was a report by Goldman Sachs in which they said, is curing illness really a sustainable business model, right? You don't make money, and this is where Chris Rock comes in. He compares what goes on often in our healthcare system in the United States to a street corner drug dealer and an addict, and how the money's not in the cure, the money's in, as he says, the comeback, right? Coming back again and again. And in another slide, Stephen Brill, who wrote an excellent book on the healthcare system in the United States, really did a wonderful, I think, critique of this sort of free market view of healthcare in the United States, because even your neo-conservative economists will say, in order to have a perfect free market, we have to have perfect information, and that is the consumer does, and perfect access. I mean, real mobility, freedom to choose from all different varieties. Well, first of all, the issue of transparency in healthcare costs in the United States is, shall we say, in the negative realm, because I think we all know, even in this marketplace, this healthcare marketplace locally, there's a wide range of different prices for different procedures, but who knows what those different prices really are. And also, unless you're lucky enough to get a decent healthcare private insurance plan, and I would also put even quotes around decent, because there's always constraints in any private healthcare plan, you essentially, you don't have access. You don't have full mobility, full freedom to choose. It's, as Stephen Brill says, it's a crapshoot. It's a crapshoot.
Okay.
Right? So this is the system that we're dealing with in the United States. And it also hasn't done very well by the citizens of the United States.
Yeah.
And that comes out in many different ways.
Okay, but you know, you always hear that, at least in the media, that this is what we have in the United States is the best healthcare system in the world. Is there arguments to say that's not the case, or?
Well,
Or data,
it's certainly the most expensive.
Yeah.
It's certainly the most expensive. And if you look at this slide, I think it's an excellent overview of the reality of healthcare costs in the United States compared to other wealthy industrialized countries. The United States is the most expensive. It accounts for 17.2% of GDP. And the next nearest is in Switzerland, and there it's 12.4% in terms of GDP. Mm-hmm. So the most expensive.
Which is gross domestic product.
Yes, gross
so
domestic.
Basically
thank
everything
you.
That
Thank you.
We,
yeah.
Yeah.
The dangers of having academics sometimes talking about these
acronyms
things, right?
are rough for a lot of us.
Right.
We use them too much.
Exactly. But you know, you might ask, well, what do we get for this?
Mm-hmm.
We're the most expensive. Surely that there should be great outcomes. Well, not really. Infant mortality in the United States is the highest of the wealthy industrialized countries. 6 out of 1,000 live births, the children die. In Canada, the next highest, 4.8 relative to 1,000 live births. Maternal mortality in the United States, 12.7 per 1,000. The next closest is the UK at 6.4.
Wow.
And on top of it, the statistics I'm giving you here, they're from about 2016. Mm-hmm. The reality is the trend's been going up in the United States, and that's contrary, particularly on something like maternal mortality, to what's going on in other countries, again, these wealthy industrialized countries that it's appropriate to compare us to. What's going on there is maternal mortality is going down. So it's going up in our country where it's going down elsewhere. And our life expectancy is also the lowest in the world, and we know
in the industrial, for the wealthy
again
industrialized
compared
world,
to the
we want to compare apples to apples.
Exactly.
Mm-hmm.
And we're at 78.8 years. Mm-hmm. Germany is next, lowest, if you will, at 80.9. And
well, you see how the Germans drink and I'd say even smoke more than average Americans. That could be probably higher than it is.
Yeah, and I mean, I think we have to admit we have more problems. We have the opioid crisis, for example, which is in fact I think a major source of why life expectancy has been going down in the United States in recent years. But the question even there is, well, what are we doing for that population? How easy is it for that population, often a poor population, right? A kind of displaced working class population, what's available to them in terms of access to the kind of treatment that may help them over this kind of addiction. What this all means, these figures that I just was citing, is according to the Commonwealth Fund, the United States, again, not comparing apples to oranges, but to wealthy industrialized countries, we rank lowest in terms of the quality of our healthcare system.
Yet we have the highest costs.
Yet we have the highest costs. So I would dare to say that our system is in crisis in the United States. And the question then becomes, what do we do?
Yes, so what is the solution?
Well, I guess you're not going to be surprised,
Okay.
right, that I think, and here we have a slide that talks about a Medicare for All bill. This slide is based on H.R. 676, which was that is a prior year's version of Pramila Jayapal's bill. So it's basically the same as what's now being considered
Just
in,
the numbers
in Congress.
change.
Just the numbers change.
Yeah.
They often do from year to year. And what does this bill do? It eliminates the current gap in Medicare, so that folks don't have to worry about supplemental drug, supplemental insurance, where there's caps, if you will, even in the Medicare program.
And that's a big issue for seniors, because seniors that retire on a decent pension, plus Social Security or Social Security, that still can maintain a middle class income, those supplements aren't too bad compared to regular private health insurance on exchanges. However, seniors that are like, say, poor and lower middle class really struggle buying those extra Medicare supplements. So that'll be gone. So basically it'll be 100% health care.
Right. So as a friend of mine likes to point out, you should actually say your bill is expanded Medicare for All, right?
Yes.
Because it expands current Medicare.
Improved and expanded.
Improved and expanded, not just in terms of being offered to more people, but also that seniors will be in better shape too.
So basically, Medicare for All, and you can elaborate a little bit on this, from what I gather is that it'll be 100% health care coverage, and we'll talk a little bit more about what it's going to cost a little bit more in taxes, but the fact is that with Medicare for All, there'll be no premiums, no co-pays, no deductibles, no out-of-pocket procedures or treatments or whatever. Is that correct? Or?
That's absolutely correct.
Okay.
And the kinds of things that get covered are inpatient, outpatient, ER, mental, vision, dental, drug, medical apparatus, long-term, so important.
Long-term health care.
Health care, right.
Because everybody, I think that's the one thing that we're probably, a lot of things we're in denial about in this country, but that's probably a big one, because that's going to affect everybody. Even before you get old, a person gets old themselves, they're going to go through it with a parent more than likely.
Absolutely.
And I've heard horror stories from people I know about how, for getting, like a parent in a decent facility, it costs more than what they make a year.
Absolutely.
Gross.
Absolutely. My husband had to deal with this with his mother, who lived to a very ripe old age, but also in her latter years was a victim of Alzheimer's and had to be in a nursing home. But basically all the family savings, and they had been small shopkeepers and had a quite, good savings account. It was gone. Just gone.
So everything they worked hard for all their lives, gone.
Absolutely.
Yeah.
This is the kind of thing that we're facing in this country. Bankruptcies. The number one cause of bankruptcies in this country is medical debt. And another thing I think it's important to say about a Medicare for All approach, which again would be publicly financed but still privately delivered, is that it would help out businesses in this country. I remember about a decade ago, and I'm not quite sure why it continued. It might have been pressure from other businesses, but business interests like the Chamber of Commerce or something. But particularly within the auto industry, there were a number of CEOs at that time who came out in support of a Medicare for All approach. And why would they do that? First of all, what's called legacy costs in big manufacturing industries like steel, like auto, et cetera, rubber in the past, basically we're putting U.S. manufacturers in a non-competitive position relative to countries like Germany, where healthcare costs were not something employers had to be concerned about.
These
right?
legacy costs you mentioned, I guess that's basically not just covering the health insurance of their current workers, but those who have retired, and
Yeah.
so that could add up to be quite a bit of money. Yeah.
Quite a chunk of change. I mean, and that's what the CEOs were concerned about at the time. Again, I haven't heard from them more recently, and although again, to get back to the business side of the equation, if you look at, and this was true most recently in the UAW strike against General Motors, but you can go back into the 70s, and this is where my involvement in labor relations informs my view. The major cause of strikes and failure to reach a agreement at the bargaining table was healthcare costs. It was always healthcare costs, right? And recently, what's happened so often is that because of the burden on employers, if you will, quote unquote, what's happened is that unions, and as their strength has been undermined in recent years, have had to give back increasingly on healthcare costs, so that the premiums go up for the unionized workers, the co-pays, et cetera, et cetera. That's why I get irritated. I happened to see something on PBS News a while back where a commentator would say that, oh, all these unions, they're going to be so resistant to a Medicare for All plan because they've fought so long for these good health insurance programs and the like. And I'm thinking, not the unionists that I know. Now, maybe individual unions haven't come out, but there have been many unions that have come out in support of Medicare for All. So this could help workers. It could help businesses if we move to this kind of approach to our healthcare system.
Okay. So it's interesting, though, that, as far as they talk about, if you've seen any of the recent presidential debates, one of the arguments that some of these candidates are saying about is people love their private health insurance, their employer-based health insurance. I mean, to me, that just doesn't ring true. I mean, I've had employer-based health insurance, and the problem is if you get laid off, you no longer have health insurance. If you all of a sudden don't like your job, and you want to go to a job you think's better, or you want to start your own business, all of a sudden you got an obstacle there as far as being able to do that, because there'll be concerns and worries about what are you going to do about health care. And also there's people that have to retire early because of health issues, or sometimes people are just fed up and they want to leave. They want to retire. They've had it. Again, they can't do it, or it's very difficult to do because, again, employer-based health care. And with Medicare for All, from what I understand, it basically starts the day you're born and goes with you wherever you happen to move to, whoever you work for, till the day you die. Is that correct? Or
fully mobile,
yeah.
Fully mobile, right?
Okay.
Because it's not employer-based. It's not based in your employment. But you're absolutely right. I mean, I can't tell you how many times I've had friends who say, I really hate this job, but I can't give it up because of the health insurance. Sometimes they're even locked into a job where they could possibly get a better wage somewhere else, but there's not going to be the health care benefits for them. The other thing about choice, I think a couple of things about choice. Because, first of all, I don't think a lot of people, and I even talked to someone recently who's a Sanders supporter, but doesn't fully understand Medicare for All. And so was kind of asking, well, will there still be co-pays? Will there still be premiums, deductibles? No, it's gone. That kind of expense to the individual or the individual family, it's gone completely. And the other thing I think about choice is, it relates also, I think, to the question of satisfaction. If you look at surveys that have been done on people's satisfaction with their health care, Medicare, you get about 6% of respondents saying that they think that the quality of Medicare is fair to poor. It's 20% for employer-based plans.
Okay.
It's 33% if you're purchasing your own. And so the question of satisfaction with, if you will, the private sphere is, it's much less than the government-run program.
But it's not really a government-run program; it's a government-paid program.
Paid program, yes, thank
Yeah, because
you.
I've had that
Thank
question
you.
asked me before. Unlike the UK, I mean, there is another option. I mean, to public health care, and that's like what they have in Britain, Scotland, Ireland. And that is basically a national health service to where the hospitals are actually owned by the public hospitals are owned by the government, and the doctors and the nurses and the support staff all are employees of the government. Very much, almost identical to our Veterans Administration's hospitals. Is that correct?
Yes, yes,
Okay.
exactly.
Okay.
But you're right. I'm glad you made that clarification because we're not talking about the English model. We're not talking about a public health system, if you will. So many people could still keep those doctors that they might love under such a system.
Well, that's the other thing I noticed about, in recent years it seemed like it's gotten worse, is that when you talk about choice, I mean, whatever private health insurance you get, either on your own or through your employer, there's always restricted provider networks. In other words, they dictate, these corporate health insurance companies tell you, if you don't go to these list of hospitals, doctors, or clinics, then you're going to be responsible for up to 60% of the bill on your own. That's just off the top, without the usual, uncovered procedures, deductibles, and all that sort of thing. So that doesn't sound like much freedom of choice to me.
And also, a lot of those plans, they're going to cap what they will pay. So if you hit catastrophic illness or you need long-term care, it's not going to be covered. That's where the bankruptcies come in, even for people who have health insurance, right?
Yeah.
And the other thing I will say, a couple of things about the choice issue. First of all, if you listen to somebody like Pete Buttigieg, he'll say, well, I believe that people should be able to have choice. What he means by that is either a public plan, a public option, or a private, if they want to keep their private. That's the only choice they're talking about. They're not talking about full choice to go anywhere in the country, to access any doctor in the country, any healthcare professional in the country, any healthcare facility in the country. That's a different kind of choice. And the other thing I will say, I'm a breast cancer survivor. I happen to have a very good health insurance program, not least because I used Loyola University's facilities and for staff.
And you're a former professor from Loyola, correct?
That's right. And essentially, it meant that I had very good health care and I didn't have to pay a lot, right? Obviously, there were deductibles that came out of my paycheck and all of that. But if someone came to me at that point and said, are you satisfied with your health care? What I have to think in my mind, and I think that that's probably true for a lot of people who are going to say, oh yeah, I like my health care, is it's so much better than what most people have.
Yeah.
You're comparing not to, in a sense, what you got relative to perfection. You're comparing to what you got relative to
how much worse it could be.
How much worse it could be with so many people face. That's, I think, how a lot of people are answering that question. You got to look at context. Got to look at context.
Okay.
So that's, I think, an important dimension.
Okay. All right. So there's going to be a workshop then this coming, I'd say a week from this broadcast. It'll be this coming Saturday.
Yes.
It's on November 16th from 2 to 4 at the Champaign Public Library. Do you want to talk a little about this workshop?
Absolutely. But, can I just address one more issue? Because
Yes.
I think it's so important because this is what's coming up in the Democratic debates and in the mainstream press and media and the like, and that's the cost issue.
Okay.
There has been a very credible study that's been done by the University of Massachusetts on, it was on HR 676, again, Pramilla's bill. Equivalent to the bill in the House at this point in time. And what they showed was that a Medicare for All plan along the lines of what she outlined, her bill outlines, would essentially save $5 trillion over the period between 2017 and 2026.
Yeah. I've heard the presidential debate, Joe Biden screaming about how it's going to cost us $3 trillion, but evidently he left out the savings of $5 trillion.
Exactly. And people will say, well, how could that be? Well, first of all, what you have to understand, yes, there's going to be increased costs. There will be increased healthcare consumption. UMass study factors that in. There's going to be transition costs because both Pramilla's bill and Bernie's bill talk about displaced workers. If you convert to a public system, they're going to be people who work for the private insurance, et cetera. They're going to lose their jobs. Yes. But in point of fact, there's money for retraining and support,
Plus,
counseling,
it seems
et
to me
cetera.
the vast majority of those people would be able to get unionized jobs in the public sector, doing the same thing they did for the private health insurance companies. But this time, instead of denying claims, they process claims for all of us citizens out
And
there.
they themselves would probably feel a lot
And
better
they
about
probably
it
feel
too.
a lot better themselves.
Right,
Yes.
right. But the other thing is, because where the cost savings comes in is in terms of your administrative costs are going to go down, because you're going to have, if you will, a single system administering, in a sense, this healthcare system. And right now, in terms of private insurance, the administrative costs are something like 17% relative to the 2% administrative costs for Medicare.
Okay.
But also, you're going to be able negotiate drug prices like the VA can do, but we somehow have failed to do that
When
thus
you say
far.
negotiate, that's basically the federal government as one entity representing all the American people will be able to negotiate drug prices and also have some regulatory power to sort of back up that negotiation.
That's right. And also, they'll be able to standardize costs. None of this nonsense of your appendectomy costs $2,000 at, for example, I'm not saying these are the actual costs, but we'll say hospital 1, and it's going to cost you $5,000 at hospital 2. None of this. There's going to be standardized prices, and everybody's going to know those prices. We're going to know those prices. So that's one of the ways. And then it is true. There are many different ways to pay for this, and that can come through taxes on the wealthy. It could come from employer taxes, because don't forget, a lot of employers that are now carrying the costs of private insurance programs, those are eliminated. There is also a possibility of financial transaction taxes. Bernie's talking about a progressive approach to taxation, which means the lowest earners in the country wouldn't pay anything at all, but it would go up over time. And around this question of increasing taxes to the wealthy, I always like to remind people, in the Eisenhower years, the marginal tax rate was 92%. We are now at, I think it's about 35%. And so there's a lot of room. There's a lot of room.
And most of the people in those very high income brackets don't pay 35%.
Oh, no, and then we won't even get into the way that you can get through tax loopholes, which Bernie also talks about ways to essentially address that. And by the way, I'd like to emphasize that, because a lot of people, again, the pundits and the like, will say, well, Bernie's not talking about how to solve the cost problem. Bernie's talking about it. He's talking about a range of options, right? And at this point in time, it may be premature to come up with the absolute approach to how you're going to pay. So.
Yeah. As far as savings, besides when you say administrative costs, I would assume that what might be covered under that would be CEO salaries.
Oh, shall we talk?
Board of directors salaries, and not to mention the actual profit for the company that they pay out to shareholders, as well as bonuses to themselves.
I mean, don't forget, in our profit-driven system, that, especially as it's emerged most recently, CEO pay is linked to stock prices. So you want to do everything you can to bring up the revenues that then lead to higher stock prices. And that means that no matter what you have to do, along the lines of the Goldman Sachs report, curing is not a sustainable business model. You want to come up with ways to have people to keep escalating prices, or revenue, be it through increased prices, like we've seen in drug prices, the incredible escalation. But the other thing is, since ACA,
the Affordable Care Act, otherwise known as Obamacare.
Yes, thank you. Since ACA, the 70 top CEOs and the largest healthcare businesses have made over $9.8 billion in salary. 9.8. The salaries of CEOs in healthcare are rising much more rapidly than salaries anywhere else,
Okay.
especially
Yeah,
manufacturing.
I think isn't the high. I saw this figure. I could be wrong, but the highest paid healthcare CEO makes $12 million a year,
Yes.
and the head of the federal Medicare system makes $350,000 a year.
Yeah, a bit of a difference
Yeah.
there, a bit of a difference. And that could help us to understand one important way the costs go down in a Medicare for all.
And that's not even including the profits to share, pay out to shareholders and plus
Dividends,
the
et cetera.
dividends and bonuses to the board of directors and the CEO on top of the annual salary. So
Absolutely.
yeah, I could see all sorts of savings there. So
Yeah.
okay,
Absolutely. And the other thing I want to emphasize is that for and the cost issue, the average family, well, there have been a number of studies. RAND, not exactly a lefty organization, has done an analysis that says a family of four is going to save at least $3,000 a year. Citizens for Tax Justice Study says about the same. And other studies will go, depending on how it's funded in terms of the tax, progressive taxes or whatever, it could save as much as 14% for people who make less than $28K a year.
I saw a chart the other day. It broke it down to income levels, and I remember the one that really stuck out to me was $60,000 a year, which is a pretty healthy middle class income. 60,000 individual who makes $60,000 a year would pay about $1,200 in total cost for their health care with Medicare for all. So that's $100 a month. I've never seen anything like that on the Obamacare exchanges.
No,
And that
yeah.
includes no deductible copay
Yeah.
premium of any kind other than
That's right.
that increase in tax.
That's right. That's right. And actually, even when a lot of these calculations about what would be saved, they're dealing with kind of average circumstances. So again, they're not looking at what you save, for example, if you have to face catastrophic illness.
Yes. Or an ongoing condition like diabetes or whatever. Yes.
So it's just looking at kind of average use.
Now they talk a lot about a public option, and could you talk a little bit about the difference between a public option and a full Medicare for all?
Well, a public option, I mean,
system.
there would be different ways it could be done, but basically what most of the folks who are talking about a public option are suggesting is to have some kind of more or less government-financed program, but it is in the context, the wider context of a remaining private insurance system. And it poses all kinds of problems, because you still have essentially this profit-driven system that probably, influences what's going on even in the public option. This came up in the terms of the discussion of even ACA, the Affordable Care Act, Obamacare, because it is true that the more people you have in any given system, the more your costs are going to go down.
Economies of scale.
Economies of scale operate. And so to the extent that you have a public option swimming in a wider environment of privatized healthcare, it's going to have problems, just like we're seeing with ACA, the kinds of problems that remain for ACA because they haven't been able to really develop those economies of scale.
So really there's a couple different options of public options.
Right.
And then one you explained is, I think, the one that is being pushed the most by people, candidates like Kamala Harris. From what I've seen is at its very best, the public option would be basically people being able to buy into Medicare.
Right.
Okay. But the problem I understand from that is that it's basically, when you have a system like that, it's basically set up to fail in the sense that when you allow the corporate health insurance companies to still stay in the healthcare system, they're going to offer younger and healthier people, mainly younger people, pretty good, decent rates on healthcare, which means that the older and sicker are going to be more or less forced to buy into Medicare, which means that over time, the costs are going to keep ratcheting up in the public option Medicare, which basically then the politicians and the healthcare insurance companies can come and say, see, it doesn't work. Costs are out of control. As opposed to having everybody from birth to 99 years old in the same pool, and you get the economies of scale effect.
Well, you made a very good point, because the issue of the pool is not just the size, it's who's in it. What are the demographics?
Yes.
But the other thing about the public option that most of the Dems are talking about, that is, those Dems that push it, they're not talking about negotiating drug prices. They're not talking about standardizing, costs of medical care. So you're essentially allowing for rapid escalation in terms of both drug prices and medical procedure, et cetera, prices. So, that doesn't help us either in that regard.
Okay. Did you want to talk about, did you have anything else you wanted to mention on Medicare
Well,
for All
I guess
before about the workshop? Or?
Well, the only other thing I will
Yes.
also say is, and we can talk more about this, and we will at the workshop. I hope people will consider coming to it. Right now, or the most recent surveys, 70% of people are supportive of Medicare for all, and that includes 52% of Republicans.
Republican voters.
Yeah.
Okay.
So anyway, but
Yeah.
yes, the Illinois Single Payer Coalition, CU, we've been doing a lot of work. We've been essentially getting signatures on petitions that are going to Senators Durbin and Duckworth, who have yet to co-sponsor. It would be Bernie's bill, the Senator's bill. And we are going to have a workshop on November 16th, Champaign Public Library.
That'll be this coming Saturday, okay?
Yeah. Well, not tomorrow, but yes,
This
I'm
coming
sorry,
Saturday.
the coming Saturday,
Yeah.
sorry. And essentially, what we will do there is we will go over some of the things we've gone over today. What's the background in terms of the healthcare system as it exists in the United States today? What is Medicare for all? And then a discussion of a sort of open discussion of where do we go from here? How do we make sure that we can get this policy implemented in the United States? And already we within the coalition are talking about things like we hope to get resolutions passed by City Council, by the County Board. We're seeing that happen throughout the country. The Los Angeles City Council just passed such a resolution. So there's work to be done. It's not going to happen. It is going to be politically feasible if there is a grassroots campaign that pushes it. As Bernie says, it's not me, it's us.
Yes, because you're basically going to be eliminating $1 billion corporate industry from an entire sector of the economy, and they're not going to go quietly, I would imagine.
No, they're not. But remember, the same kind of dynamics, it was a little different in terms of the political sphere, but when Medicare, the original Medicare came up,
1965?
1965, the same forces were arrayed against it. And nevertheless, it was passed and it was implemented within 1 year. Even Bernie's bill now is talking about a 4-year full implementation
And Kamala J. Paul's 2 years. So
So
now, a lot of people might say that this just never happened. It's impossible. The forces you're up against, these multi-billion-dollar companies, you grew up. Well, you were in I guess high school during the civil rights movement. Okay.
Yeah.
I mean, that time and maybe before when you were younger, did you ever imagine that there could ever be a change in this country in terms of segregation and civil rights?
Absolutely not. Absolutely not. I mean, I do remember and being very impressed. I lived on the northwest side of Chicago. My father was a Chicago policeman, so we lived in what still is sort of the uniform civil service community of Chicago because they have the residency requirement for civil servants. And I remember Martin Luther King coming to Jefferson Park and seeing him march down Milwaukee Avenue and being very supportive. I was sympathetic, even as a high school student, but I certainly didn't think that things would change. I was seeing, what was going on in the South, the water hoses, the brutality, the dogs, etc. Who thought you could move against that? But
it was the law of the land. I mean, right?
Yeah.
And if we had somebody old enough that maybe lived through the women's suffrage movement of the early part of the 1900s, I imagine they'd probably have a similar story. So that's what I try to tell people is that when the people want something bad enough, that it basically need something bad enough, that if they unify and organize, they will get it, and it's been done many times in the past. I always like to say that nothing has ever changed for the better in the U.S. or world history, for that matter, I think, without a struggle of people having to, actually fight for it. And when I mean fight, I mean, organize and come together and push and do the work that needs to be done to have it happen. I mean, because the civil rights movement didn't just happen because Rosa Parks sat down one day, Martin Luther King made a couple speeches. I mean, it was long and it was it was pretty brutal at times even. Not to say that's going to happen with single payer, but I'm just saying.
I hope not.
No, but I'm just saying that there was a lot. It was besides those kind of more historical highlights, if you will, as far as the drama. Behind the scenes, there was tons and tons of people doing work. I mean, working every day on this. When they weren't working at their jobs, or if they were retired, to take time out of their free time to actually put the work in to make this happen. So I guess I'm just wanting to say that hopefully you agree with me that it's gonna, they're not gonna just give this to us.
No, and what I would also say is that in terms of the Illinois Single Payer Coalition, it's open to both organizational reps and individuals, and we're hoping to be able to recruit more people in. And we don't necessarily expect that you're going to give us 8 hours a day in terms of volunteer work for the coalition. But if you can even give just 1 hour a week, a couple of hours a month, when we get to the point maybe where we're doing door-to-door canvas or whatever emerges as the activity that our group wants to engage in, I hope people would consider doing it, because this is so important. And even if you yourself are not facing a healthcare crisis at the moment, you will in the future. That's unfortunately the reality of the lifespan, for that matter.
Yes,
but
indeed.
I couldn't agree with you more. It's nothing ever changes. People will talk about the New Deal. The New Deal, the most progressive aspects of the New Deal occurred at the point where union and community activism was at its highest. That's when the decision was made, we got to pass some bills here,
Okay.
right?
Well, Patricia Simpson, thank you so much for coming on Labor's Worldview TV, and look forward to the workshop coming up this Saturday at the Champaign Public Library, and that's from 2 to 4 p.m.?
That's right, 2 to 4.
Okay, well, thank you very much.
All right, thank you, David.